Hello everybody, I'm not Aileen O'Brien, I'm Louise Clark. I'm also involved in this project. I'm an Honorary Nurse Consultant at South West London and St George's on the Psychiatric Intensive Care Unit, which incorporates the 136 suite, and I'm also a lecturer at King's College London in mental health and intellectual disability. Okay, so Section 136 has been in the headlines quite a lot lately. Just for those of you who aren't aware what it is, it's a section of the Mental Health Act 1983, which was amended in 2007, which basically means that the police can detain somebody on the street and bring them to a place of safety. That place of safety may vary borough to borough, but across our 5 boroughs, which are Wandsworth, Kingston, Merton, Sutton, Richmond, generally people come to the 136 suite at Springfield. There are local variations. I don't know if any of you saw recently a panorama programme about Southampton, where people were generally taken to the police cells, and obviously that varies throughout the country. But police cells are currently holding more than 9,000 mentally ill people a year. Nationally, between 2010, there were 7,035 assessments, because obviously once the person has been brought in under a Section 136, they then need to be assessed by 2 Section 12 approved doctors and a social worker, an AMP. So obviously this is quite expensive. But in 2012 there were 14,900 assessments, but no increase in numbers of people who are finally detained under the Mental Health Act and kept in. Why do you think that could be? A lot of it was down to drugs and alcohol, which is an increasing problem. So a lot of stuff in the media, mentally ill people held by police too often, and obviously the Southampton panorama programme showed how though they did have a couple of mental health nurses actually working on this massive 136 unit, but probably that's not enough, and the police are not comfortable with it. So this can often end up in us on a unit, perhaps we've got capacity for 2 people at any time in single, quite secure spaces, but we might often end up with a queue and ambulances waiting outside. So this is a situation that we have to try and address as best we can, especially as the staffing for the 136 suite. This happens in our trust and across a lot of other trusts in London. It has to come from the Psychiatric Intensive Care Unit because of the specialism of the nurses who are trained in emergency and acute psychiatric interventions. So that will take nurses from the ward very often. Okay, so the setting, it's Building 30, 136 suite. It covers the 5 boroughs, serving 1 million people. Admissions over 6 months. This was a pilot study that we did when we realised that we had a problem. We had 245 people admitted, 57% were men, and 71% of all of them were white. The average age was 37.2, and they went between ages 15 to 83. And since this study was done, we actually had somebody a few months ago who was 8 years of age. 45% have threats of self-harm. So management while they're with us can be quite problematic. 44% were intoxicated. That also means we cannot assess them until after they have a much lower breathalyzer reading. So they can be with us if they're intoxicated for 10, 12 hours. It's a long time. 61% have had previous admissions or been in 136 before. Okay, so reasons for sectioning under 136 in this 6-month pilot study that we previously did. The threat of self-harm, 40.8%. Bizarre behaviour, 20.4%. Combination, 13.1%. Actual self-harm, 11.8%. Violence towards others, 11.4%. And violence towards property, 1.6%. And others were 0.8%. Okay, so when we started to look at alcohol, we had 81 people, that's 33.1%. Drugs, 14, combination of the two, 13. And remember, not all drugs can we screen for. We had a lady who came in a couple of weeks ago who we thought had probably been a victim of Rohypnol, and we couldn't actually screen for it there and then. So it's quite difficult sometimes to actually know if it is a combination. Men were more likely to be intoxicated, patients more likely to be sent home if they were intoxicated straight away, obviously from having been assessed. And 22 repeat presentations over the 6 months, 78% of those being intoxicated. Okay, so looking at a comparison of reasons for determinant, intoxicated versus non-intoxicated patients, so you can just take a look at that, and some of them obviously combinations. So threats to self-harm was the most common reason for 136, and 108 patients, which is 44.1%, found to be intoxicated, and intoxicated patients had longer assessment times and a decreased likelihood of admission to hospital. And obviously they are then taking up those beds and assessment suite in a tiny unit across 5 boroughs. So the aims of the project were to improve physical assessment of patients in 136 suite, to introduce a system whereby the outcome of the 136 assessment and looking at results, and to provide information about services to patients when they're in there, hopefully to try and deal with the alcohol problems, and to train staff to deliver a brief alcohol intervention. So what we suggested was, once the patient had started to come down off their alcohol, probably after they'd had their assessment, a short evidence-based approach, probably using CAGE most commonly. If you all come across CAGE, it's a very simplistic tool, basically looking at, have you ever thought, how much do you drink? Have you ever thought about cutting down on your alcohol intake? Have you ever been annoyed when people have suggested that you drink too much? Have you ever felt guilty about your drinking? And have you ever had an eye-opener? That's the E, eye-opener in the morning. So I'm sure that you've come across this before. So this is what we're basing it on. And we're non-confrontational. We've actually, when we've done the training for the staff, we've said, it's a better idea if you're actually taking them outside once they've been assessed and they've calmed down before they go home and they want a cigarette, sitting with them while they have a cigarette and doing it in a very non-confrontational manner to see, if the patient, and very often the patients have been so traumatised by the fact that they've been detained in a 136 suite, they feel quite upset about it. It can be quite a traumatic event, and they're happy to actually admit to it and talk about it and see a way through. So I think the other thing that we try and do then, we've taught the staff some sort of brief motivational interviewing techniques, looking at as well, giving leaflets, giving information about where they can go to for help. Partnerships in this project are obviously the police, because we work very closely with the police over 136 suite, primary care, because we're sending the patients back onto primary care afterwards, and community substance abuse services, IDAS particularly. So progress to date, we've appointed a nurse to run the project, our lovely Christine sitting over here, and phlebotomy training for all staff so that we're able, all RMNs, so that they are able to take bloods if patients will agree to this for liver function tests, so that we will then agree to have those results sent through to their GPs so the GPs can follow up as well. Our links to KCA and IDAS, and obviously handing out lots of leaflets on that, and the training of the staff which has begun. Also, about 4 months before we started this sort of second phase of the project, we've handed out patient satisfaction forms, and funnily enough, something like 95% of patients will fill them in. And that's not just patients who've come in with alcohol problems, and we're really pleased that people have actually said their stay was very enjoyable. It's the endless cups of tea and pieces of toast and offers of cigarette breaks outside, I think. So evaluation. To evaluate, we're looking at the numbers who are going to agree to the intervention and the audit, the numbers who will then agree to having their blood tests done for liver function, the satisfaction of the patients, looking at, is this sort of changing, is this getting even better? The views of staff around this, do staff really think it's making a difference? We'll look at those returns in again in 6 months and then hope to work with primary care. The next stage for us is to actually be able to follow patients through 3 months down the line with a phone call. We'll need ethical approval for that. So that will be the next stage that we will look at. We see this as a long-term project because we have to do something to cut down the numbers of people coming into 136 Suite. Okay, thank you very much.